Assalamu alaikum. The presentation today is on anterior knee pain, open door to the patellofemoral joint. The content of these presentations, we are going to discuss the definition and differential diagnosis of the anterior knee pain, patellofemoral syndrome, anatomy and biomechanics of the patellofemoral complex, risk factor and the etiology and pathophysiology of the patellofemoral pain syndrome, clinical presentations of the patellofemoral syndrome. Actually, the clinical and radiological evaluations and the different modalities of management of the patellofemoral disorder will be discussed in the next presentation in the same sessions with my colleague. What is the anterior knee pain? It's an umbrella term which includes a wide range of related to significantly different conditions result into pain around or behind the kneecap. It accounts about 1/3 of the musculoskeletal problems seen into the primary care, common in overuse injury in sport medicines, more prevalent in athletic patients, especially the runner. This is the most common differential diagnosis of the anterior knee pain, which include the iliotibial band syndrome, articular cartilage injury, symptomatic bipartite patella, bone tumors, chondromalacia, plica, osgood-Schlatter's, patellofemoral arthritis, referred pain from the hip, prepatellar bursitis, loose body Larsen-Johann syndrome, and patellofemoral pain syndrome as the most common causes of anterior knee pain. What is the patellofemoral pain syndrome? It's a common condition causing anterior knee pain around and behind the patella in both athletes and non-athletes and in both men and women that aggravated by weight bearing and knee flexions. It could be idiopathic anterior knee pain, runner knee, retropatellar pain syndrome, and lateral facet compression syndrome. It's actually account about 20 to 40% of patients presenting with anterior knee pain. What is the anatomy and biomechanics of the patellofemoral complex? It's the diarthroidal plane joint that consists of the posterior surface of the patella and the trochlear surface of the distal anterior femur. The role of the patella is to increase the lever arm of the thigh muscles to allow them to work more efficiently and to reduce the fractions of the patellar tendon on the trochlea and to protect the femoral condyle from direct pressures during and wear and tear during squatting position. Due to the shallow and incongruent fit between the patella and the trochlea, the stability of the patellofemoral joint is dependent on static and dynamic soft tissue structure. The static stabilizers anterior is represented by the patellar tendon and the joint capsule, laterally the lateral patellofemoral ligament, joint capsule, iliotibial band, superficial and deep lateral retinaculum, medially by the medial patellofemoral ligament, which is responsible for 60% of the total strain at 20 degrees of knee flexions, and meniscofemoral ligament. The dynamic stabilizers consist of the quadriceps muscles, pes anserinus muscles, and biceps femoris muscle. Vastus medialis obliquus promote a medial stabilizing force to the patella. The result in the pull of the quadriceps and the patellar tendon, which reduce at the Q angles. What is the Q angle? It's an angle lie between two intersections between the anterior superior iliac spines and the midways of the patella, and the line 2 between the tibial tuberosity and the centers of the patella. Biomechanically, it's formed by the vector of combined pull of the quadriceps muscle, femoris, and patellar tendon. Normally, it's about 10 to 30 degree, 13 degree in males and 15 to 17 degree in females. It's more wider in females due to wide pelvis and increase into the femoral anteversion. The higher Q angles increase the lateral pull of the quadriceps femoris muscle on the patella that potentiate patellofemoral disorder. What is the patellofemoral reactions force? It's affected by the quadriceps angles and the angles of the knee joint. In knee in full extensions with have a minimal compression force on the patellae. As the knee flexions increase, the compression force are increased. The patellofemoral compression force is actually affected by the gravity. In a stance phase of walking during knee flexions 20 degree, the patellocompression force is about 25 to 50% of the body weight. During ascending stairs, it's about 2 to 3 times of the body weight. In running, about 5 to 6 times of the body weight. Flexion greater than 90 degree, it's equal about 8 times of the body weight. In squatting positions, it equal about 20 times of the body weight. What is the factor affecting the patellar tracking? The local factors include the the tight iliotibial band or lateral retinaculum, the lax medial patellar retinaculum, trochlear dysplasia, and weakness of the quadriceps muscles. The global factors include excessive genu valgum, external tibial torsions, and the extensive femoral anteversions associated with foot pronations. The etiology classified into intrinsic factor, extrinsic factors, and other. The intrinsic factors include alter in the biomechanics of the foot, alter in the biomechanics of the leg, anatomical anomaly, medial and lateral patellar mobility, soft tissue tightness, and muscle imbalance. In the case of the foot with subtalar joint pronations, there is an increase in the tibial torsions during the terminal knee extension. For compensations of that, the femoral are rotated externally, which leading to increase into the Q ankles. The malalignment of the legs, such as femoral anteversion, genu valgum, and genu recurvatum, and the external tibial torsion increase in the Q angle that later on increase into the lateral patellofemoral contact pressure and the extensive laterally tilted patella. Anatomical anomaly include dysplasia and the hypoplasia of the patella or trachea, patella alta, patella baja, and which leading later on into mild tracking. Medial and lateral patellar hypomobility. This study stated that in hyperflexity there is inflexibility of the surrounding patellar muscle group, which increase into the medial and lateral patellar movement with rapid translations of the patella and development of patellofemoral pain syndrome. Soft tissue tightness. In case of gastrosoleus tightness, there is a decrease in the dorsiflexion of the foot, which compensated by subtalar pronations and increase into the valgus force and increase into the Q angle. Tight hamstring muscles, the knee flexions at the heel strike increase into the quadriceps activity, which later on increase into patellofemoral compressions force. Tight iliotibial pad, dual lateral trackings by traction on the Copland's fibers, leading to lateral tilt of the patella and increasing into patellofemoral compressions force. Soft tissue tightness at quadriceps, that restrictions of the full extraction of the patella into the tracheal groove, causing lateral tractions and increase into the patellofemoral compressions force. Tightness of the lateral retinaculum predisposed to the extensive lateral pressure syndrome that leading to tilting of patella. Weakness of the hip muscles, decrease in the abductors and the external rotator, which mainly occur in the female, leading to extensive abductions and internal rotations, which leading to increase in the Q angles. Weakness of the quadriceps muscles, decrease the activity of the vastus medialis obliquus. So the vastus lateralis activated before the vastus medialis obliquus, that leading to the maltrackings of the patella. The extrinsic factors consist of extensive durations or frequency of physical activity, error in training such as sudden increase in the mileage, activity changes of the training surface, inappreciated footwear such as high heel shoes. Others, regarding the females, it is a wide greater valgus knee, leading to increased internal rotation and increase in the Q angle, generalized ligamentous injury, increase the patellar mobility, which affect the patellar tracking. The knee spine syndrome, Morhata et al. 2003 showed that where there was a correlation between the patellofemoral joint pain, lumbar lordosis, and sacral inclinations in elderly patients with anterior knee pain. Psychological patellofemoral pain syndrome, Jensen et al. 2007 shows that the pain and the knee functions can be associated with psychological factor and the higher level of mental stress in some patients with long-standing patellofemoral pain syndrome in comparison with the healthy subject. This is the algorithm explains the pathogenesis of the patellofemoral syndrome. In the case of eversions and the planovalgus with tight abductors muscles, these are dynamic force of the leg, which make later on the patellar maltrackings. Also with the low back pains, there is increase in the sacral inclination, which make a flexion contraction of the knee and increase the compression force on the patella. Tight hamstring, leading to dynamic valgus and flexion contractures. All of them are leading to stress on the patella and reduce a patellofemoral pain syndrome. The clinical presentation, the patient actually presented with pain, giving way, swelling, stiffness, crepitus, pseudo-lockings, and popping or catching sensations. The demographic data, the age presented usually between 10 or 40 years old, female more common than male, athletes and military recruits. The chief complaint, as we said before, pain, crepitus, giving way, locking, and swelling, and stiffness. The pain actually is not unclear as the source is not clear, but it usually arising from the sensory structures associated with sensory nerve ending, such as the subchondral bone, insertion of the extensor mechanism, synovium, retinaculum, and fat pad. The onset of the pain is insidious, gradual, and can be precipitated by trauma. The area affected is pre-patellar, retropatellar, and behind and underneath and around the patellae. The pain is diffuse, dull ache, with sometimes coming sharp. What is the aggravating factors of the patellofemoral pain? Descending stairs is more common than ascending, going up hills or walking on incline, standing up from squatting, movie or theater signs which the patient has a severe pain after prolonged knee flexions. Relieving factor, extension of the knee and wrist. Conclusion, anterior knee pain is one of the most common musculoskeletal complaints of the young and adult patients. The pathogenesis of the patellofemoral pain syndrome is multifactorial, but the primary contributor include instability and the overload of the subchondral bone. Abnormality in the static and dynamic stabilizers of the patella play an important role in the development of patellofemoral syndrome. Q angle is a good indicator for patellar maltracking. Thank you very much.